Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a patient comes to the acute medical unit with sudden severe vertigo, vomiting, and inability to tolerate head movement. They have spontaneous nystagmus, but no hearing loss and no tinnitus. The key question for MRCP is this: is this a benign peripheral vestibular problem, or is this a posterior circulation stroke pretending to be vertigo? Vestibular neuritis, also called vestibular neuritis, is acute unilateral peripheral vestibular hypofunction due to inflammation of the vestibular branch of the 8th cranial nerve. In simple words, one vestibular nerve suddenly becomes underactive, so the brain receives unequal balance signals from the two ears. That asymmetry is interpreted as false movement, and the patient feels continuous vertigo. Now let us orient ourselves with the anatomy, because once the anatomy is clear, the symptoms become much easier to understand. Here is the outer ear leading into the middle ear, and deeper inside is the inner ear. In the inner ear, the vestibular apparatus is responsible for balance, and the cochlea is responsible for hearing. The vestibular apparatus has two main parts: the semicircular canals, which detect rotational movement, and the otolith organs, which detect linear acceleration. Here is the superior semicircular canal. Think of the movement you make when drinking soup, a forward and backward pitching movement of the head. Here is the lateral, or horizontal semicircular canal. This is involved when you turn your head side to side, as if looking laterally. And here is the posterior semicircular canal, which is involved with the movement of bringing the head towards the shoulder on either side. Now look at the utricle and the saccule. The utricle mainly detects forward and backward acceleration and deceleration, especially in the horizontal plane. The saccule mainly detects up and down acceleration and deceleration, especially in the vertical plane. So semicircular canals deal with rotation, while the utricle and saccule deal with linear movement. Next, look at the vestibulocochlear nerve. It has two major functional divisions. The cochlear division supplies the cochlea, so it is responsible for hearing. The vestibular division supplies the balance apparatus. The superior vestibular nerve supplies the superior and lateral semicircular canals and also the utricle. The inferior vestibular nerve supplies the posterior semicircular canal and the saccule. This is why the clinical presentation makes sense. If the vestibular nerve is inflamed, the patient has vertigo and imbalance. But if the cochlear nerve and cochlea are spared, hearing remains normal. That is the key distinction in vestibular neuritis. The suspected mechanism is usually post-viral inflammation, and herpes simplex virus reactivation is often discussed as a possible trigger. You can remember this association by thinking of Ramsay-Hunt syndrome, where herpes zoster affects the ear region and facial nerve. The exact mechanism in vestibular neuritis is not always proven, but the useful clinical model is this. Viral inflammation leads to vestibular nerve edema, which leads to reduced firing from one side, which leads to asymmetric tonic vestibular input to the brain. The brain compares left and right vestibular signals all the time. If one side suddenly fires less, the other side appears relatively overactive. The brain interprets that asymmetry as rotation, even when the patient is lying still. That is why the vertigo is continuous and can be present at rest. Head movement makes it worse because the already abnormal vestibular system is stressed further. Superior vestibular nerve involvement is common, so the lateral horizontal canal is often affected. This gives a horizontal vestibulo-ocular reflex abnormality, which becomes very important when we discuss the head impulse test. Hearing is preserved because the cochlear nerve and labyrinthine hearing structures are not primarily involved. Clinically, vestibular neuritis presents with acute or subacute onset continuous vertigo lasting days. This is not a 10-second positional spell. This is not a brief faint feeling. This is sustained spinning vertigo, often with nausea, vomiting, oscillopsia, and gait unsteadiness. Oscillopsia means the visual world appears to bounce or move because the vestibulo-ocular reflex is not stabilizing gaze properly. The patient may veer or fall towards the affected side because the tone from that vestibular apparatus is reduced. The important negative feature is no cochlear symptom, no hearing loss, no tinnitus, no oral fullness. MRCP trap. If there is continuous vertigo for days plus hearing loss or tinnitus, think of labyrinthitis rather than vestibular neuritis. If there are recurrent episodic attacks of vertigo with fluctuating hearing loss, tinnitus, and oral fullness, think of Ménière disease. The nystagmus in vestibular neuritis is usually spontaneous, unidirectional, and horizontal torsional. It tends to beat away from the affected ear. Remember, nystagmus is named by the fast phase, not the slow phase. So in right vestibular neuritis, the right vestibular nerve is underfiring. The eyes slowly drift towards the right, and the corrective fast phase beats to the left. That is called left beating nystagmus. Now let us move to diagnosis. Vestibular neuritis is mainly a clinical diagnosis in the setting of acute vestibular syndrome. Acute vestibular syndrome means continuous vertigo, spontaneous nystagmus, nausea or vomiting, and gait unsteadiness. This is the correct setting for using HINTS. HINTS stands for head impulse, nystagmus, and test of skew. It is not for every dizzy patient. It is for the patient with continuous vertigo and spontaneous nystagmus. Used in the right context by someone trained to perform it, HINTS helps separate peripheral vestibular neuritis from central causes, especially posterior circulation stroke. Start with head impulse. This tests the horizontal vestibulo-ocular reflex. Ask the patient to fix their gaze on a target, usually your nose. Then rapidly turn the head a small amount to one side. In vestibular neuritis, when the head is turned towards the affected side, the weak vestibular apparatus cannot keep the eyes locked on target. The eyes slip off the target, and then a corrective saccade brings them back. That corrective saccade is an abnormal head impulse, and in this context, it supports a peripheral lesion. MRCP trap. In severe continuous vertigo, a normal head impulse is worrying. Stroke can produce severe vertigo while sparing the peripheral vestibulo-ocular reflex pathway, so the eyes remain fixed on target even during the head impulse test. Normal head impulse in acute vestibular syndrome is a central red flag. Next, assess nystagmus. In vestibular neuritis, the nystagmus is usually unidirectional horizontal torsional. It keeps beating in the same direction, although the intensity may change depending on gaze direction. Central nystagmus is more concerning when it is direction changing, vertical, or pure torsional. Then perform the test of skew. This tests vertical ocular alignment, involving otolith pathways from the utricle through the vestibulonuclei to the ocular motor nuclei. You cover one eye, then uncover it, looking for vertical corrective movement. In typical peripheral vestibular neuritis, there should be no skew deviation. In a brainstem or cerebellar stroke, one eye may sit higher or lower, so uncovering causes a vertical refixation movement. So the peripheral HINTS pattern is abnormal head impulse, unidirectional nystagmus, and no skew. That pattern supports vestibular neuritis. The central HINTS pattern is normal head impulse, direction changing or vertical nystagmus, or skew deviation. Any one of these should make you think posterior circulation stroke until proven otherwise. Now, when should we image? MRI, brain, and internal auditory canals should be considered when there are central signs, significant vascular risk factors, severe headache, focal neurological deficit, inability to walk, atypical nystagmus, or diagnostic uncertainty. In practice, if the patient cannot stand or walk unaided, has direction-changing nystagmus, has skew deviation, has a normal head impulse despite severe ongoing vertigo, or has focal neurological signs, do not simply label it vestibular neuritis. Treat it as a possible posterior circulation stroke and assess urgently. Let us contrast the common differentials in a practical way. Continuous vertigo for days with no hearing loss points towards vestibular neuritis. Continuous vertigo for days with hearing loss or tinnitus points towards labyrinthitis. Recurrent episodic vertigo with fluctuating hearing loss, tinnitus, and oral fullness points towards Ménière disease. Severe continuous vertigo with focal neurology, direction changing or vertical nystagmus, skew deviation, severe truncal ataxia, or a normal head impulse points towards a central cause, especially posterior circulation stroke. Now treatment. In the first 48 to 72 hours, the patient often needs supportive care. Give fluids if dehydrated, control vomiting, and use a short course of vestibular suppressants or antiemetics when symptoms are severe. Examples include prochlorperazine, meclizine, or a benzodiazepine in selected severe cases. But do not continue vestibular suppressants for too long. The brain needs to recalibrate. This recalibration is called central compensation. If you suppress the vestibular system for days and days, you can delay recovery. So the principle is, control severe symptoms early, Then stop suppressants as soon as possible and encourage mobilization. Early mobilization and vestibular rehabilitation are central to recovery. Repeated head and eye movements feel unpleasant at first, but they drive central compensation. The brain gradually learns to reinterpret the unequal vestibular input and restore functional balance. Corticosteroids given early, particularly within 24 to 72 hours, may improve vestibular function recovery, but the evidence is mixed. So they can be considered if there is no contraindication, but they are not the same as the essential treatment principles. Exclude stroke when appropriate, manage severe symptoms briefly, and start vestibular rehabilitation early. Antivirals do not have a clear routine benefit in vestibular neuritis, even though viral reactivation is suspected in the pathophysiology. That distinction is important for exams. Suspected viral mechanism does not automatically mean routine antiviral treatment. If you remember one thing, remember this: vestibular neuritis causes acute continuous vertigo without hearing loss, with a peripheral hints pattern. The dangerous mimic is posterior circulation stroke. MRCP trap: do not diagnose vestibular neuritis just because the patient is dizzy and vomiting. First ask, is this acute vestibular syndrome? Are there cochlear symptoms? And are there central red flags? Do subscribe to the channel for further videos.